Okay, we'll get started in a second. I'm just testing if YouTube is working. Okay, guys, good morning. We'll get started with this. We left off almost halfway through this chapter. Any questions before I get into the material? Okay, so I believe, if my memory does not fail me, that I left off Friday with this slide. We covered, go the wrong way. We covered a little bit about Pseudomonas and showed some details about it and this piocyanin production, the green, blue-green kind of, more green, pigment that it has the potential to produce dependent upon the type of media. It also has some fluorescents that allow it to fluoresce under UV or black light. So that's where we left off. And now we want to think about acne. Maybe we don't want to think about acne. There's all sorts of potential issues as we start thinking about this, but deep down, it's really the result of clogged follicles that sets the stage for organisms to really kind of thrive in this new sort of habitat that they have. I guess the best way would be to say become trapped in as the follicle gets clogged. So you can see here this follicle, normal skin pore, everything all fine and good, and then white or blackheads as a result of the clogged pore and the organism growing within. So the white and blackheads, again, the result of these clogged follicles. The blackheads, you can see the visible spots as lipids, oils within the skin start becoming oxidized as they are exposed to the air. And you can see on the nose here, handfuls of, well, clogged pores with blackheads. Shifting gears the littlest bit, this bacterium is definitely one that we will see mentioned in a couple of different chapters. And I guess, well, there's a table here in 1 second that will talk about acne. So I didn't even mention the bacterium. Doesn't matter. I'll mention it in just a second. Anthrax, Bacillus anthracis, is a bacterium that can cause numerous types of infections. Cutaneous anthrax is relatively common. It kind of depends upon your circumstances. If you are agricultural worker, there is greater likelihood of coming in contact with this organism just through contact with soil, or potentially you could think about maybe animal hides, sheep, and the sheep shearing process sets the stage maybe to come in contact with this stuff. Cutaneous anthrax has been described as wool sorter's disease because it was relatively common for sheep herders, and again, the people shearing the sheep, maybe more specifically, that may not be the sheep herder, sets the stage for a skin wound and the inoculation of the bacterium into that wound, giving you this cutaneous form of anthrax. So here we can see this lesion, this ulcer. It's blackish with necrotic tissue within there. So this black eschar is, as it looks like, it's kind of scabbing over, looks like it's healing. It's really necrotic tissue. It's not necessarily, I would not describe this as in the healing process. If not dealt with, it will progress and continue to grow, if you will. This is a type of auger called sheep blood auger, or blood auger is typically what we just call them. Most of the time when I think about these things, it is sheep cells that are incorporated into the auger. But in doing a little evaluating of some of these types of media, I have realized that there's more than just sheep blood that they use. And sometimes you get differing types of reactions dependent upon the types of erythrocytes that are incorporated into this media. I think that's kind of interesting. More interesting for me as I was looking into that. I was under the impression until just a little while ago it was always sheep blood. But that's not the case. Horse erythrocytes are one that is utilized as well, probably more expensive with that. These are relatively expensive plates, something that we don't readily utilize in the intro labs. We typically try to use these at least one time. We have done some bacteria of the body in the intro labs where you've got the opportunity to evaluate all sorts of different areas, swabbing your skin, putting them onto MSA plates that you're familiarized with already, I would assume. There's also the potential for like a throat swab, thinking like strep throat testing. That's typically placed onto a blood auger plate. And we usually, like I said, do some of this stuff with our current conditions with COVID and issues. We have decided that the bacteria of the body is something we're just not going to deal with. Oftentimes, swabbing throats requires a partner. It's pretty difficult to swab your own throat. And we just felt like it's better to not put ourselves at risk dealing with that stuff. So, like I said, typically you get at least one opportunity to visualize a blood auger plate and potentially see some of the characteristics of that, but we're not going to mess around with that stuff this semester. So these plates typically are bright red as a result of those erythrocytes, whatever animal they're really coming from, but again, in this case, sheep blood. Usually it's 5% sheep or blood cells that are added. This is all added aseptically after the plate has been prepared and the auger has been autoclaved and cooled. And as it's just about to solidify, they incorporate the red cells, because otherwise autoclaving those red blood cells would cause them to be destroyed. And then this plate would be a chocolate auger. No chocolate involved. It's just lysed red cells. All right. So the anthrax grows beautifully on these blood auger plates. You get great growth. Bacillus, lots of types of bacillus grow in this fashion that we call swarming. They will spread and grow really very rapidly. So if you're not on top of it, this plate can be overwhelmed with cells, if it's allowed to incubate for, 3 days or something. But these kind of characteristic colonies, indicative of bacillus, and potentially maybe once you start looking at some stuff under the microscope, you get a little better clue that maybe we're really looking at anthrax. These are very large, microscopically, very large gram-positive rods, maybe some of the biggest rods that you've seen. When you start looking at it, you're like, wow, I've never seen anything quite like that. And if we're thinking cutaneous lesions like that, it should be a good indication you've got something like that going on. So like I said, Friday, as we're moving through these chapters, there is a tremendous amount of information. There's a lot of diseases that we're going to be thinking about. There's a huge amount of organisms as we move along. There's also potentials that we will see a lot of these players mentioned in subsequent chapters, because they have the capability of being pathogens in numerous body sites, some not, all right? So I do recommend that you pay attention to these tables in the text or in the PowerPoints, and potentially maybe thinking note cards or something like that to help get you thinking about the specific types of organisms. Here you can see pyogenes listed repeatedly for all sorts of different things, and we're only on the skin, all right? So keep that in mind. So we started today with acne, and I didn't mention the bacterium. Here it is right here. Propionibacterium acnes is the pathogen, the culprit for causing these issues. And, ultimately we've got this organism, this normal flora on our skin. And it's just a situation as far as, your environment, what you are providing for this organism that sets the stage for maybe a outbreak, if you will. So as we think puberty, excessive amounts of oil production, that really sets the stage for these guys to thrive, if you will. So there's all sorts of potentials with this, differing types, white and blackheads. There's papules and pustules, some nodules, and some types of acne that are pseudocyst-like, very large, often painful. It's not transmissible. It's a result of clogged pores and contamination of the normal flora within those pores, or inoculation, basically clogging it up and keeping it in there, and then, well, it's in the right place and it thrives. So there are some antimicrobial agents that can be utilized. The cutaneous form of anthrax, like I said, we'll see it again because there's other types. Bacillus anthracis, again, is the culprit, the eschar, that black necrotic lesion, and the potential for these guys as they get in and start causing issues to make their way into the blood. That sets the stage for septicemia, as you've got replicating organisms within the circulatory system. When we say you're septic. And if that happens, it can very likely be a fatal infection. So typically we think about, the bacillus and the clostridium. These are two gram-positive rods that are these spore-forming organisms when we think about pathogens. There are a couple of other genera that can form spores, but we don't think of them as being pathogenic, so we're not going to focus on that stuff. So bacillus, it's often coming in contact with these spores that really sets the stage for the issues in the first place. The spores get inoculated into a lesion and in turn are able to replicate. Again, a few antimicrobials that target. Cellulitis, ehrlichias, and erythema nodosum, all Streptococcus pyogenes as the culprit. And, similar issues. We showed some of this stuff Friday as we were moving through. Impetigo is a mixture of organisms. We also talked about impetigo Friday. Impetigo is the result of infection with both Staph aureus and Streptococcus pyogenes. Oftentimes, we see one and then the other. There are some instances where maybe both could be cultured at the same time. It sort of depends on circumstances and maybe timing of when you were actually looking at that infection. So all sorts of issues with this, and with it is definitely something that's contagious, especially thinking about close contact, setting the stage for easy, maybe readily transmissible types of organisms. So the necrotizing fasciitis, there's a handful of organisms that can fit into this. The Streptococcus pyogenes was really the one we were thinking about as we were showing those initial images. It kind of fit right along with that, but there's others. Klebsiella, Clostridium, Clostridium that can, Clostridium perfringens that can cause gas gangrene is a potential, and oftentimes we can see kind of a mixture of situations resulting as you get this necrotic tissue, and maybe other microbes are like, oh, this is the perfect situation for me. Maybe almost thinking impetigo, like where you've got a couple of different players. There may be others participating in this as well. So infection of the fascia, and it does spread very rapid and can ultimately lend to death if not treated very quickly. So bacteria get in through cuts or abrasions, and in turn, treatment with some broad spectrums definitely are important, right? And there are, you know, these are just a few as we think about this. There are other microbes, you know, given the right opportunity, wrong place at the right time, sets the stage for them maybe getting into these into a scratch or a lesion, something like that, and they manifest in a similar fashion. But these are the main ones we think about. The external ear, otis externa, Pseudomonas aeruginosa is a good one for that. As it gets inoculated, as I think we did show some images that kind of looked like sort of a shiny colony as they were growing on the plate, indicating a capsule layer, a protective mechanism for these guys to avoid being recognized by our immune response. And it also sets the stage for biofilm formation and makes antimicrobial therapy relatively, well, it's kind of a moot point with that. You just know it's not going to be effective almost when it's Pseudomonas. There are other potentials, some acidic eardrops that may help to get in and target through that capsule layer, and if they also harbor some other agents that might drive a wedge in there. But it is, again, a difficult one when we're thinking about it. We showed an image of an infant with scalded skin syndrome, staphylococcal scalded skin syndrome, and it is a very severe, like all of the skin basically sloughing off is really kind of how it looks. So skin and mucous membranes get targeted, and it's definitely more common in infants, in newborns, really. So wound infections, Pseudomonas, and others set the stage for that. Pseudomonas is a very good one when we think about burn patients, severe burns, like third-degree burns. Pseudomonas can colonize in these individuals, and it becomes very difficult to combat. And you can see, you know, as we saw, that greenish pigment, the pyocyanin, that's being produced. Oftentimes in these individuals, you get pus that appears that color. You know there's something going on, and you need to try to deal with that as quickly as possible. This next image, this is conjunctivitis, pink eye. There's all sorts of potentials as far as culprits that may cause some of these issues. We can see the redness, we can see lots of discharge, and it really kind of depends on the circumstances as far as what you might be getting, right? So acute purulent bacterial conjunctivitis, there's viral culprits with this as well. You see swelling and redness, and the potential, to move from one to the other eye, because it is definitely a contagious situation. You can see both being impacted, oftentimes waking up in the morning with your eye kind of glued shut as a result of all of the discharge over the night. And that's maybe your first indication you got something going on. After you finally, with the washcloth, get it all wiped away, you recognize your eye is red, inflamed, and well, issues for sure. This is definitely more severe as we look at this. This is a newborn with gonococcal ophthalmia neonatorum. It is something that is a result of in transit through the birth canal, the child gets inoculated with gonorrhea, and there's serious issues. This ultimately, there are other STIs that can fit this category, but this is definitely one example as far as why antibiotics are placed into the child's eye as soon as they hatch out into this world. It used to be silver nitrate that was added, and now it's an antibiotic that they put in there to prevent this issue in the first place. Even if mother has a clean bill of health, if they are born in a hospital in the United States, they get antibiotics placed in their eyes as a protective situation. So ultimately, if nothing is done, it can result in permanent blindness. So serious issue. And it is, it's still a type of conjunctivitis. It's just a little bit different and definitely more severe than thinking Haemophilus causing the pink eye that's common. Trachoma, this one is, if it is not treated early, it can lend to some serious issues and scarring of the eyelids, leading to trichiasis, and ultimately the eyelids or eyelashes, excuse me, turn inward on the eyelid. And that is not what you want to have happening. It also has the potential to lend to blindness, again, if not dealt with or corrected by surgery once this starts to happen. And that's what we're looking at here, trying to go in and flip them back around. So with this handful of bacterial infections, we're going to shift and think a little bit about some fungi here in a second. But the bacterial infections of the eye, the acute bacterial conjunctivitis, typically it's Haemophilus influenzae that we think of as the culprit with this. There are potentials for some other, but usually, again, as far as bacteria go, Haemophilus is a big culprit with that pink eye, right? So transmission, exposure to secretions from infected individuals, it is relatively contagious as a result of that. And broad spectrum antibiotics are common. I remember, thinking pink eye, a couple Olympics back, Winter Olympics, because we just missed this last one. I think it was the one before that, if I remember right. Bob Costas, who was the commentator for NBC for all sorts of stuff, was at the Olympics, and he shows up one night with a issue with a little bit of pink eye going on. He battles through and seems like it's all fine and good, but you can tell it doesn't seem so fine and good. The following day, he shows up and both eyes severely infected, very red. He just looks terrible. And then they get a new commentator in to take his place because they're just lit flat. People don't want to see him. And he ultimately can't read the teleprompter, I'm sure, because his eyes are so messed up. Like poor Bob Costas. And whenever I think of Pink Eye now, forever, it will be Bob Costas that I think of. I ought to find a picture and have it up here for you. I'm sure there's one available. He doesn't want that. Bacterial keratitis, Staphylococcus epidermidis, normal flora on your skin. In this case, does have a potential to set the stage for some issues. And our friend Pseudomonas. So redness and irritation, blurred vision, light sensitivity. If these organisms are allowed to progress, you can see corneal scarring, and it may result in blindness. So oftentimes with this, contact lens wearers are more likely to become infected in these circumstances than people that don't. So that's just the contacts ultimately being contaminated can set the stage. So some eye drops, antibiotic eye drops as a mechanism. The neonatal conjunctivitis, Neisseria gonorrhoeae was the one we showed initially, and then chlamydia trachomitis was the one with the eyelashes potentially flipping inward either way. You see this as a conjunctivitis. Definitely more severe, more of an issue than our top one. All right. And it's again exposure in the birth canal to some STI. Trachoma, this chlamydia trachomitis, it's same as up above, but now we're moving down. The issues again with this, there is also potentials for infection from flies that would have contaminated mouth parts moving from one individual to another, transmitting this infection just by contaminated mouth parts. That's relatively disturbing to think about. Okay, so this next image, shifting over the littlest bit, we've got a couple of images of some warts. They vary in shapes, they vary in locations. There's all sorts of potentials with this. So multiple plantar warts on the toe, and then a filiform wart on an eyelid right here. I think that would be very irritating as I see that. So these viral, all right, papillomavirus is a viral infection that stimulates excessive skin production, the warts that we see manifesting. And again, there's all sorts of possibilities with that. We'll see some more details with that here in a bit. This next image on this person's lip, this is a cold sore. And this cold sore in this case is caused by herpes virus, herpes simplex virus 1, type 1. There are handfuls of herpes viruses and different types of manifestations as we move through here. As far as skin, we think of type 1s and type 2s resulting in these types of lesions, typically type 1 around on the face, around the mouth usually. Type 2 we think of as common, more in the genital region. But with that said, it doesn't necessarily have to be that way, and there can be type 1 or type 2 in either area. Kind of just depends on the circumstances. So a couple of other viral infections, a lot of the time it's little kids, infants, when you see this stuff. And otherwise, you pretty much don't think about it. Or maybe if you do happen to contract roseola, you don't even, it's asymptomatic. You don't even know you got it going on in the first place if you're an adult. But usually it's something that you've had as a child, and it is both of these really pretty common childhood illness. Roseola, definitely a common rash illness that you see in little kids. And if you have kids, anytime they get feverish, anytime there's rashes, anything like that, there's concerns. And there's all sorts of things that you start wondering. Could it be some sort of food situation? Are they having a reaction that way? Fevers typically aren't seen in food reactions like that, so that raises another flag. And with roseola, oftentimes fevers can be relatively high. That sets the stage definitely for some concern. As far as both of these guys go, it's relatively mild overall and self-limiting. All right. Oftentimes, as we see here, this kid almost looks as if we've got a little smile on the face. Doesn't seem too impacted by this. All right. It really kind of just depends. Our youngest son had roseola and didn't seem like there was any real issues at all. Little feverish, and that definitely was made him a little uncomfortable. But as far as real symptoms go, not really that big of a deal. So in both circumstances, you can take them into the clinic, but you'll leave empty-handed. There's nothing really that you can do with this. Maybe little Tylenol or something to drop the fever, but otherwise, there's not much you can do about it. All right. And with that, the fifth disease, which is this B, oftentimes on the face, it kind of almost looks like a slapped cheek appearance, very red on the face, and that is something you see with fifth disease, but you don't see it with roseola, not the slapped cheek appearance, but definitely rash like we're seeing on the legs here. Not the best, but they do look very similar that way. All right. So fifth disease is a parvovirus B19, different than the parvo that you vaccinate your dog for, but similar sort of an idea. All right. Similar groupings, if you will. All right. So may have some initial cold-like symptoms, and then the rash resulting after. It is very contagious, and we think respiratory droplet transmission. But again, typically it's little kids that are really where you see more of this occurring. Herpes keratitis, this is your simplex 1 inflammation, and again, depends on where we're looking at. If it is within the eye, there's definitely issues, and that's what we're looking at here, infection within the cornea, and some issues, all right, potential blindness. Oral herpes, again, type 1, and the cold sores that we see with acyclovir and some other antiviral agents fit with that. The papillomas, these are the warts, human papillomavirus, and there are handfuls of different types, as the image we looked at a second ago kind of implies. Common warts, plantar, flat, filiform, and some others. And it is something that is, we see infection from contact with others that are infected. So something that we would say is contagious. So topical salicylic acid, and some other mechanisms, but ultimately the acid helping to deal with that. So roseola, this is another herpes, human herpes 6 or human herpes 7. So different than the herpes simplex, right? But a relative, if you will. Another one that starts off kind of cold-like symptoms, and then you see a high fever. After that, you see the rash a few days after the fever starting to show up. So, and there are maybe some antivirals if we're thinking immunocompromised, but otherwise not. Viral conjunctivitis, so different then the bacterial conjunctivitis is still impacting the eye. But in this case, instead of the purulent discharge, instead of the green or whitish discharge, the eye getting glued shut in the morning, this is different. This is a watery, non-purulent discharge. You don't think about the eye being glued shut in the morning. It's different, all right? Very runny, watery eyes that definitely a different appearance and manifestation than the bacterial conjunctivitis, all right? Oftentimes associated with common cold. And you see this occurring, watery eyes, right? So it is contagious, and contact with eye discharge can set the stage to be readily transmitted to somebody else. Okay, fungus. As we shift over to this, there's handfuls of types of fungi, and these first ones we want to think about we call dermatophytes, so infecting the skin, all right? Taenias are the groups, the types of different fungi, and it's really kind of a misnomer. Taenia means worm, and looking at figure C here, ringworm, which is not a worm, a type of taenia, in this case, Taenia corpus. Again, not a true worm. It is fungus. And all of these, some type of taenia. Taenia barbae is a fungal infection on the face. And in this case, barber's itch, if you will. So infecting hair follicles, and the fungal organism gets in there and replicates, and you can see these lesions. There are handfuls of different types of dermatophytes that can cause these infections, and you can see them in differing areas. So same one causing Taenia barbae could be causing other issues elsewhere on the body as well. But when we see it manifesting there, we'll give it a different name, all right? So Taenia pedis means the foot, and in this case, athlete's foot, something really pretty common. Itching, burning, dry, cracked sores, typically between the toes. And in all circumstances, as we look at this treatment, some sort of topical antifungal cream, maybe some spray, some quick-acting tenactin sprayed onto the foot. It's an antifungal agent. It's quick-acting in the fact that it stops the pain and the burning, but you have to continue to spray that onto your feet, typically multiple times a day for about a month, for it to kind of do its job, all right? It is difficult to target fungal infections, all right? And when we're talking these dermatophytes, there's definitely some problems. Some treatments, medicated powders can enhance the sloughing off of the skin, basically helping to shed those layers of skin that are infected with the fungal organisms, and basically help to rid yourself of that maybe a little quicker. So Taenia corpus, ringworm, and in this case, here's one of the culprits. And like I said, these handful of different dermatophytes. Trichophyton is one that can cause these issues, and whatever. We'll see a table of this that lists them off here in a second. Epidermophyton and microsporium also can fit into here, and all can have, dependent upon the body site, different manifestations. So this ringworm, this characteristic typically, seen on someplace on the body, on the face or scalp, maybe on appendages, something like that, arms, legs, and it looks, again, from gross observation, looks as if maybe there's a worm underneath the surface of the skin. Like I said, a misnomer, because it's truly fungus. So This relatively common circumstance if you have little kids and maybe pets, dogs and cats, the potential for this to be shed from a pet to a child is relatively common. So you want to kind of be cautious with that. And if both wind up with it, you need to treat both of them, or you're never truly going to get rid of it. So fungi, we can grow them on media like we think about growing bacteria, but they're different. They look different, right? It's also something that we look at the surface, and we also look at the bottom side of the auger to see how that appears. And that can be informative when we start trying to differentiate fungi, all right? A special type of media to grow fungus is called saccharode agar. It's really selective for fungal organisms. There are some saccharode media that are incorporated with antimicrobial agents to enhance the selective properties. Not all of them have antibiotics in there, and so sometimes a saccharode plate will get a little bit of skin organism bacteria on there as well. But for the most part, really, they focus in on fungal organisms. So if we go back to this, taking a little sample of any of this, a little scraping from it, trying to get some of the organism with that's in the skin, and incorporating that onto the plate, incubating it. Fungi does take longer typically to grow, but incubating it on this plate for upwards of maybe about a week, all of a sudden you get good fungal growth, and again, potentially able to differentiate. So Trichophyton rubrum is a dermatophyte that we can see right here, and there are others, right? So causing tinnias in various parts of the body. And like I said, just depends on where it's at. Could be tinea barbae coming off of the face, or tinea capitis if we're thinking your scalp, right? Or whatever. Here is a different type of fungus, Aspergillus, and we've got an image, this eschar. It does look a little bit different than the anthrax. Looks quite a bit different than that. So this is secondary cutaneous aspergillosis. As you see the image of the fungi right here, these guys growing within this lesion. So this image of the aspergillus, this is a conidiaphore. This is a reproductive structure of that fungi, and here are all of the spores on it. So the hyphae, the thread-like stalks that the fungi utilizes are also seen there. So this candidiasis, Candida albicans, is a type of fungi, but in this case, instead of molds like the aspergillus or the dermatophytes we were just looking at, the trichophyton, Candida is a yeast, and these yeast cells grow differently. Their appearance on a plate is definitely different than the filamentous or mycelial growth that you see with molds, right? So here we've got cutaneous candidiasis, red rash-like lesions, kind of crusty on there, nail infection. In this case, Tinea unguium, and it can be the result of some dermatophytes. It also can be candida, so a couple potentials with that. The nails get very yellow and brittle, break. Some treatments for some of this stuff would be application of some, I can't remember the name of the substance, but it's basically crystal violet, the dye that we use in gram staining that's going to stain gram positives. You put some of that onto the nail, it's going to be purple, all right? But it ultimately gets in there and kills the fungi, which I think is pretty impressive. Now, if all of my crystal violet disappears from the lab, I'm going to know there's issues. Someone's got a nail infection. All right. The Candida albicans over here growing on a sabarobe plate. You get these big growths in it. Let me flip it back to my plate with a type of mold, very wrinkled, maybe even fuzzy looking appearance. And then with this creamy, it almost looks bacterial like as you see some of these yeast cells growing on there. They definitely are more pronounced. They grow really well in this situation. And if you were to take some off and stain it up, you would see very large, thick cell-walled yeasts and potentially see them in the process of dividing as well. So with the mycoses of the skin, this table lists a handful that we've thought about. The aspergillosis, Aspergillus fumigatus and flavus are two potentials. So they get into a wound or potentially into the respiratory tract, setting the stage for the secondary form of it after it's manifested within the lungs and then disseminated. That's bad news. And it is a potential for hospital acquired infection. There's issues with that. So azole drugs are antifungal agents. Amphotericin is another antifungal. Candidiasis, the cutaneous form, again, treatment with some azole, and it can be overgrowth of normal skin flora. So just dependent upon circumstances. We didn't show this in here, but we mentioned it a while back. Sporothrix sporotrichosis is Rose Gardner's disease. And this, not just rose bushes, but other plants that have, capability of causing some abrasions, some scratches on your skin. Maybe these plants have some of this fungi colonized on it. And as you are pruning these shrubs or rose bushes or whatever it might be, you get some lesions and the fungi gets inoculated under the skin. So subcutaneous ulcers, potential for abscess, and issues, right? More azole drugs. And the taenias. So like I said, there's a handful of them. Trichophyton, epidermophyton, and microsporium are the three main players that we think about for these taenias, these dermatophytes, skin infections. So itchy, ring-like lesions at varied sites on the body. So transmissions coming in contact with the dermatophytic fungi, setting the stage for it, all right? Athlete's foot in a situation like in a gym, the floor of the shower, many people utilizing that nice warm environment, lots of moisture, setting the stage for it to be readily transmitted from one person to the next. There are numerous issues when we think about some of these things. And if you have athlete's foot, you want to be cautious because the potential for you to inoculate other areas of your body are definitely there, all right? So thinking about, after you have bathed, how you are getting dressed is potentially important. Putting on your socks before you put on your underwear is probably a good idea, all right? Because otherwise, if your feet touch your underwear and then you have the potential to inoculate that down there, now we're not talking athlete's foot, all right? It's other issues. Same player, all right, just in a different body site. And, I don't think you really want that in that area. Oftentimes that's been described as jock itch, but there's other names as well. And what well, now I can't remember the Taenia name. Like, I mentioned Barbae and Capitis and Ungum for the nail. The one for the groin, I can't remember that. Matters not. Okay. I'm going to quit right here. We will pick up with the Canthamoeba on Wednesday. This is a good one. Good stuff. Okay, so some protozoal organisms are where we will transition. All right, any questions or concerns? Sure. When will the extra credit be graded? I have started grading some of that, and I'm going to hopefully get the rest of it graded very soon. So if you have not yet seen your grade posted, it will be soon. Okay, and there's more. I see more chats. Specific things. So you don't need to think about all of the different antibiotics. I'm thinking names and like specifics with some of the symptoms that you might be seeing. That's probably what we're thinking about. Newest, I don't know what that newest fear is. Is it the athlete's foot in other areas of the body? That's a bad one. All right. And the extra credit stuff is up for the graph. Yes, that's what I'm talking about, graph extra credit stuff. Other questions? Okay, guys, have a great day.